Hi everyone, my name is Gregory, and today's topic is biological width. By looking at this picture, everyone has this patient in the office. Either it's going to be our patients or the patients from another dentist. And many times I hear from other dentists that they fear what should I do next? How they handle the situation? Why this happens in the first place? Why is it that the temporary the patient had and the gum was beautiful? What happens when after cementation of those permanent restorations, patient developed this kind of symptoms? There's a lot of questions and a lot of answers, but which one is right? A lot of dentists are afraid they already developed this kind of mistake. What should they do next? How they can fix this problem? If they do fix the problem, will it get worse? What kind of reference point they have to use during the treatment? So today, during my presentation, I would like to answer that question. I would like to close the gap between the fear and success in your dental office. So before we start making any kind of clinical decision, especially in this case, I don't know this patient, I don't know this doctor, but what the doctor said, it's what the patient had, the temporary veneers, and everything looks beautiful. And after the cementation of those laminates, the patient developed the symptoms. So let's a little bit speculate why it happens. Sometimes dentists do not deliver the restoration the same day. And what we usually do is without even taking the impression, we prep the teeth, put temporaries in the patient, and let him go. Patient will come back next week, and the temporary looks great, the tissue looks great. But the problem is the tissue looks great, but it's not mature yet. What happens sometimes, that's the margin of the preparation a little bit above the tissue. What dentists start struggling between the eyes and the brain. Should I prep or not to prep? Should my margin go down? My restoration is going to be a little bit above the margins. What should I do? And most of the time, eyes win. And dentist taking the prep down to the gum. What happens after delivering the case, patient develop this kind of symptoms. It's biological width violation. So the most important for us when we go through all these cases is to find out what's the anatomical limitation for us in a healthy tissue and a tissue which is swollen right now. That's what you see on your screen. We have to also, before we start making decision on a clinical, what risk factors patient has from perio, from bio, occlusal, and aesthetics. So let's guess what we can do in this case. Number one, we can do ortho. If we do the ortho, do we have enough root length to do the ortho? Second of all, that the patient wants to have ortho treatment. Second, if we do crown lancering procedure, if we open up the roots and we have to redo the restorations, the laminates will not bond to cementum, so we have to change the restoration type. We have to be more aggressive, but the patient wants. Second of all, it's when we open up the roots, the patient have more sensitivity. If you're prone to cavities, he'll get more cavities on that side. Root canals. Do you see that we can't even think about only one decision in this case? The other case, will probably solution for this case is to remove the existing restorations. If the dentist didn't put a shoulder or any chamfer around the margins, it just was knife edge, we can probably prep the teeth a little bit higher and fix the problem. So you can see with one problem patient has, there's a lot of solutions, but which one is right? So today, before I start answering the questions, I have to go to the basic, how it started. So we have to know the histology, we have to know the anatomy, how the patient or the body will react at the soft tissue and the bone tissue. You look in this picture, it's a familiar picture from a textbook. Gargiulo in 1961 developed these three parts of the biological width. You know, the biological width term is not right, it's because it's biological length, not width. But also in the biological width there is a horizontal component. If you look at the picture, you know, the biological width says 2.4 millimeter. And it's connective tissue, junctional epithelium, and sulcus. Ask yourself, when in a clinical situation you probe a sulcus 0.69 millimeters? The answer is no. Because sulcus, what you see here, is a histological term, measurement. When you probe, you're always going to probe to junctional epithelium. So no matter what you do. That also depends how much connective tissue is going to influence your clinical result. That's what the difference between the course and the spear education, where the course is believe in the bone, the spear, how much connective tissue, how much the deep is the sulcus, depends how he's going to prep the teeth. Connective tissue, you're going to feel when you probe. When you start probing it, the patient feel pain or say ouch. That's your right in connective tissue. Connective tissue, when you put a cord, you see the bleeding. That's you start tearing the connective tissue. Connective tissue is strong, where the patient will come back to your office and the tooth is loose. You know, it's hanging on with the soft tissue, which hardly attached to the tooth. It's very hard to remove it. That's part of the connective tissue. So I'm going to show you with the cases how we deal with connective tissue and how it's going to influence your clinical result. Look at this picture. When my patient comes to my office, my hygienist or myself will probe the clinical sulcus. And when we measure, we put in a chart. That's what we call peri-probing. When the patient come back next time for any restorative stage, like crowns, laminates, and I'm the patient, and I probe to the bone. The probing will depend, of course, on how much power the clinician has when do the probing. How healthy the tissue. The tip of the perio probe, is it blunt or is it sharp? So I get to the bone and I measure the distance of the bone to the bone, and I minus the clinical probing. It will give you the amount of connective tissue. Second, if I see the position of my bone is very low, I tell the patient that we have possibility of recession or black triangle before we start any reversal procedures in the office. So I have to inform the patient there's possibility my restoration is going to be more squarish, or the teeth, the restoration is going to be a little bit longer due to recession, that the patient wants it. If that patient doesn't want, so I have to speak to him or discuss about other clinical procedures which are going to improve our aesthetic result. The probe you have to choose. So when you probe to the bone, it will not slip against it. So I use Hugh 3D, you'll see in my presentation, the plastic probe. I don't have any financial interest from any other companies. The probe I chose is because it's clearly visible during the clinical procedures. You can choose the metal one. I didn't choose the metal because during the sterilization process, sometimes those black circles disappear. It's very hard to read. If you want to read a little bit more of clinical article wrote by John Coyce, you can read by altering gingival levels, the restorative connection, part 1, biological variables. So let's go to the dental-gingival complex. I want you to understand that it will be two pictures which we have to remember by heart. So we know that 85% the bone crest is from the margin, from the free gingival margin to the bone is 3 millimeters. We call normal crests. It's 85% of the population. The high crest, which is good for us, is only 2%, but it's the distance from the free gingival margin to the bone is less than 3 millimeters. And that part is we can risk for biological width violation. It means we have to, if we go deeper as a normal prep, we're going to violate biological width. So we have to keep in consideration those patients. The 13%, it's a low crest. It means it's a difference, the distance between the free gingival margin to the bone is more than 3 millimeters. And those people are at risk for recession. It means when we prep the teeth, when the restorative, when we're trying to cement our restorations, we can see the margins a little bit higher than the gum. And it was beautiful. It's at the day of preparation. So this kind of patients, there is a risk of recession. The another probably scheme you want to see is the position of the bone, as we discussed right here on top. But I want you to concentrate the attention to the keys of the facial position of the bone. The measuring most of the time, as you say here, it's 3 millimeters. It also depends on the phenotype or biotype. You know, there's a lot of discussion how you determine which one is thick, a thin tissue, and there's a lot of studies done by this, and no one has known how to determine it. So usually I use clinical judgment in my office. If I see my probe through the tissue, there's a thin tissue. If I can't see, I mean a thick tissue. The another thing what's most important is the position of the gum. It's based on the most coronal position of the bone, from the line angle to the line angle. How it looks clinically. So look at this picture. There's 3 implants and all crowns. And in this position right now, I want to show you how the line angles projects on the patient's mouth. You see the vertical lines, that's the line angles. And that is line angles what most people making mistakes when they prep the teeth. Because at this level right here, sometimes when we use the wrong diamond bore, if we use like a diamond bore with a flat end, what happens when we prep the teeth, our wrist start moving in different direction, and especially interproximal. When the interproximal, we leave ledges. Now the ledge, we have to come back and we start adjust the preparation, and when we start adjusting preparation, we'll go deeper than it should be, and then we start violate biological width. So my whole message, I usually use KS chamfer bores, okay, and with those kind of design of the bores, you don't have to change the wrist position when you prep the teeth. The another clinical tip, what I start interproximal and go to facial. So I start interproximal on the distal, for example, go to the mid facial, and then I start from mesial facial and go to mid facial right here. That's how we can control it. Another important line we have to remember. You see the line right here? We call scallop. The scallop of the bone usually follows the scallop of CEJ. The scallop of the bone never follows the scallop of the gum. So the scallop of the gum is always usually higher than the bone. And the more difference between the scallop of the bone and the scallop of the tissue, the more we have a risk of having black triangles. So look at this picture. Look at the position of the gum around tooth number 7, especially on the facial. It looks alright, looks healthy. Let's look at X-ray. Again, everything looks within normal limits. When we open up, we can see there is dehiscence, recession of the bone. But the position of the gum was holding by position of the bone from the line angle to the line angle. Now you understood that the mid-facial probing will not give any clinical result for us. But look at this picture again. What kind of conclusion we can make from this picture? We can see by doing ortho and position of the tooth in different directions, we can make a clinical crown lengthening procedure without even doing surgery. So just keep in mind, when you do ortho, we can always position the tooth if we have to level the gingiva around the teeth. So let's go and look at the different dental-gingival complex, but in the proximal. You can see the normal crest is a range from 3 to 5 millimeters. My number is number 4. The high crest is less than 3 millimeters. Okay, and it's going to be a risk of biological width violation, as we knew in before. The low crest is more than 4 millimeters and a risk of black holes. So let's go and see the keys for this side. So the measurement has to be 4 millimeters, and I'll tell you why. Again, the relationship has to be depends on also on the thickness of phenotype. This is the most important line. The base of the gingiva will depend the most coronal position of the bone on a tooth or on adjacent tooth. And I'm going to show you the clinical case, how it is going to affect your clinical result. The another home take message, you have to remember that the papilla will hold if the roots distance between each other has to be 2 millimeters. So before we go with more details and clinical cases, I want to share with you though another information probably you have to keep in mind to make our clinical decision. Look at the position of the gum. The position of gum from aesthetic point, it should be canine, central, and canine in one level position. The lateral incisor has to be 0.5 or millimeter down compared to the other front teeth. What the scallop means? It means position of the facial bone to interproximal. The height is 3.5 millimeters. Just keep it in mind. That's a scallop of the front tooth. It's 3.5 millimeters. And you can see the scallop from the front teeth, and we'll go to posterior ones, is diminished in numbers. Look at this study right here. I know everybody looked at the Tarnoff case, a Tarnoff article where he says it's 5 millimeters, but actually it's 4 millimeters. If you look at the Tarnoff article, it says it is no 100%. What happened is there was a 6 millimeter pocket on adjacent tooth and 4 millimeter on the same tooth. but actually the median number was 5. The actual which you're holding this was soft tissue. It was 4 millimeters, but not 6. So look at the picture right here. You can see the IDR, it means at the radical distance between two roots should be 2 millimeters. And you have 4 millimeters between the free gingival margin to the crest of the bone. Get 100% of the time. If we go to 5 millimeters, you'll see the number go down. But look here, it's a 1.5 is also getting 100%. That's why when you place the implants, they've been asking to place your implant to adjacent toes. It's 1.5 or 2 millimeters distance. The reason is so to hold papilla. Now you know why the orthodontists, when they're trying to squeeze to close the triangles, black triangles, they're trying to do IPRs to move your roots of the patient closer, get closer to 2 millimeters to get 100% of the papilla. That was a study that's in 1982, and they're called denudation. Denudation means they literally remove the papilla from the patient till the bone and wait how the tissue is going to react. And what they say, there's no difference in attachment level prior to and 3 years after the treatment. It means the tissue grow back again with the same attachments they had before. The mean distance is 4.33 millimeters between the gingival margin and the bone level. You can see it's 4 millimeters. It's only part of the body. When you cut the soft tissue completely, it will grow back again with the same attachment. Another study was done in 2009 that the embrasure morphologies did not affect central papilla height in subject with papilla recession. What it means, that's the morphology between the embrasures will not affect central papilla. Of course, it says also the further study of the interaction among these factors is necessary. What it means to you that sometimes on lectures you will hear that the people squeeze, do something with papilla to grow. Nothing will affect that. The tissue will grow back again. Just give her time. To make again the decision, our clinical decision, as I said, we can't just look at the biological with separately. We have to look from the aesthetic point, from facially generated treatment plan. So the Misch in 2008, there's a study that's in order to determine the incisal age of maxillary, we have to look at the canines. Look at the position on this patient. It's a repose picture. When the patient says Emma and relax, you see the muscles relax. But to determine the incisal position of the front teeth, we have to look at the canines. Why the canines? Because it's a more stable position compared to the incisal edges. We're not sure how much the lip moves up and down. Okay, is it short lip or the long lip? Then I think the key over here that's even the patient numbed, you can still determine the incisal position of the canines. The discrepancy on the numbers is going to be +1 and -1. So you know that if it's more than +1, we'll call it the VME, vertical maxillary excess, and patient needs orthodontic surgery to help aesthetically. The another picture is this picture of the smile line. This picture shows the position of the gum. And usually the lip moves from 6 to 10 millimeters. If the lip moves more than 10 millimeters, it means the patient has hypermobility of the lip and need probably fillers or buttocks to restrain the muscles. The another clinical sign we need, the number, it's 10 millimeters of the central incisal length. It varies from a 9 to 12 millimeters, depends how it fits to the face. But usually the average number is 10 millimeters. Will come to the conclusion. If you remember from the distance from the free gingival margin to the bone is 3 millimeters. So from the incisal edge to the bone is 13 millimeters. If we keep in mind it's the 10 millimeters length of the incisor. If we know the scalp is 3.5 millimeters, so from the proximal to the crest of the bone, it's 9.5 millimeters. Why we need these numbers? Because people have pathological attrition, so we can probably see that's how much the patient lost. Okay, do we have to do crown lancering procedure or have to do the ortho? So what's going to give us a reference? So those numbers is going to help us to make a clinical decision. On posterior teeth, I usually run like 7 millimeters from the occlusal plane to the apical. If I have 7 millimeters in the proximal, it means I have enough of tooth structure to hold the crown. If it's not enough, I inform the patient before we start the procedure that we need maybe additional procedure to be done, a crown lengthening. So look over here. This is 9.5 because 3.5 it was the scallop. The papilla should take place 40 to 45% of a tooth structure length. So let's look at the first clinical case. This patient presented in my office with a complaint it's she doesn't like her front teeth. So by looking at this case, we have to look at the position of the papilla between different teeth. Look at the position of the papilla between central and lateral. Why the papilla higher compared to the two centrals? The reason is, remember, it's the root position between each other. It's less than 2 millimeters. Well, less than 2 millimeters, you have recession of the bone. So the bone is not here to hold it, to hold papilla. So, of course, if we look at the case, we can probably the patient needs ortho, but she doesn't have any occlusal problems. The only ortho she needs is for a cosmetic point. So she doesn't want to do any ortho, but it's possibility. Let's just a little bit speculate. Why this crown is a little bit shorter than this one? Maybe patient had a early trauma and it was like a passive eruption of this tooth. Maybe if this tooth would be virgin, we can probably push with orthodontically without exposing CJ and place a laminate, so it'll be less aggressive. But in this case, the patient already had the trauma, had the root canals, and what we decide is to look at the position of the gum where it's supposed to be. Remember the rule, the canine, central, central, and canine. So they're going to give us a position where my margin is supposed to be. And from that position, I have to check what the bone is. So what I did, I used soft tissue laser, remove the soft tissue. That's going to give me a level where I can start doing the measurement to the bone crest. By start doing the measurement, I find out do we need the crown lancering procedures on those teeth. So what I done, at the crown lancering, I removed the teeth, we took the impression, and that's the final result. You can see the position of the papilla still almost the same. The reason is even I changed the embrasure between those teeth, it's still the same position. The reason again, remember the root levels. Okay, the position of those. So that's the final result. Patient was happy. So in this kind of case, you can see during the prep, I took the impression. I can predict the position of my gum by knowing the position of the bone. Let's look at another case. This patient presented to me on an emergency basis when she broke the lateral incisor. You can see the margins all the way down, and we have to do a crown and a crown lancing procedure. This view from the occlusal. So we did, we used the CEREC blue cam and we fabricate the crown. So the crown margin will give me a guideline where the bone is supposed to be from the margin. You can see we violate biological width on the mesial, on the distal, and also interproximal. That's why we flap this case, the difference between the first one, because we have to go interproximal. You can see I've been using whittled chisel. You can buy this from Hugh Freedy or Stoma. But the most important, you have to pay attention. It's you have to make sure that there is a laser lock right here, okay, or groove, as designated like a 3 millimeters. So when you do the surgery, you know that you are 3 millimeters away from the gingival margin. You can see I removed the bone from the line angle to the line angle as on the facial view. But look over here. And remember, it's the papilla be holding by position of the bone interproximally on the tooth or adjacent tooth. So what I did, I removed the bone only partially interproximally to keep the bone on adjacent tooth to hold the papilla. You can see I didn't remove the whole bone, just partially. Okay, we place 2 stitches and the patient 1 week after. Look at this case. It's a more complex case. Patient came, she wants to change those 2 crowns and made them cosmetically right. You can see there is a biological width violation. So I can't put in mind it's the position of the gum right now. So I have to determine what the position of the bone. So look at the case right here. I've been using my perio probe to determine where my bone is. You can see that proximally on number 8 I'm short. It means I don't have enough 4 millimeters at the proximal bone. I look at adjacent tooth, even shorter. I measure my clinical crown and it's 10 millimeters. Should I make it longer? Should I make it less? Again, I have to make a decision looking at the patient's face. I measure the bone on the facial, on the line angles. You see it's not in the middle, the line angles, and it's less than 3 millimeters. I know there is a biological width violation on this side. I look at when I open up the flap, you can see the position of the bone. So every measurement I did, it looked the same. It was read right, and a violation everywhere in every step. Look at it from a different angle. So I did the crown lancing on all those 6 teeth. Here you can see 1 week after the procedure was done. Look at this patient. That's my pro bono case. And the patient been complaining it's anesthetic part of her mouth. That's she had this bonding for more than 30 years and she wants to get rid of them. Look at again, it's the position of those teeth when she smiles. You can see the different position, the gum level between lateral incisor and central. I also want to see that how sometimes if we can use tack teeth instead of wax up to determine the position of the teeth, so for patient education as patient smiles. Look at the position of the roots. It's more than 2 millimeters, but thank God she has a thick tissue. So I decided to put the brackets and move those teeth together to make sure I have distributed the spaces between the teeth, so it'll be more conservative. You can see here in a week after, you see how the teeth moved. So to create more space, I use my flame diamond, cut the piece like IPR, and you can see that's at the final stage when the brace is being removed. So I remove the bonding and I see how much tooth structure do I have. Is it going to be enamel bonded restoration? Is going to be dentin bonded restoration? So it depends which one do I have, will depend on my prep. This is a clinical procedure, how I do a crown lancing procedure without raising the flap. So I can use, so I'm using right now a scalpel, cut the soft tissue to the level where it's supposed to be. You can use the floss, okay, to measure the distance, to put a little bit mark on top of the gum, so you know where to cut it. You can use a laser, but this time I've been using my scalpel and I made internal bevel cut. You can see I've been doing on tooth number 7. Make sure that I develop a nice scallop. And I do the same procedure on number 10. Again, you see that on number 10 I've been using 2 cuts from interproximal to mid-facial. It's very easy procedure. I usually have my whittlested chisel on every crown and bridge instruments, so I don't have to look for the instruments. It's right there if I need to do crown lancing procedure, so I have instruments on my side. So almost done with this developing the scalp around the gums. Now I measure my bone level from the free gingival margin. You can see I have less than 3 millimeters of the bone, and you see this I've been probing from the line angle to the line angle. And I do the same on the opposite side. Now you can see I've been using whittlested chisel. I'll go right below the gum level, under the gum, but look at my finger on top of the tooth structure. Why? Because I'm trying to avoid slip my instruments deeper into the gum so I can control it. And you can see the movement what I do to remove the bone from a line angle to the line angle. Of course you have to use sometimes different instrument. If the bone is very thick you have to raise the flap, but most of the time the bone is very thin. Now you can see I start measuring the bone and it's 3 millimeters from the line angle to the line angle. Now I have to do the same procedure on another side. You can see, look at the movement what I do with the chisel, and make sure when you buy the tip of the whittlested chisel very thin so it can go underneath the gum. And again I start measuring my bone level. So then I use my scaler, Cavitron, and try to smooth the margins after my surgical intervention around those teeth. You can see you can use any kind of Cavitron, it doesn't matter which one. Okay, and try to go around those margins of the bone, reach the bone and make it smooth. Now I've been using a scaler 4L and 4R again to go around and smooth the margin of the bone. You can see the 2 teeth been done maybe less than 10 minutes. You can charge the patient for that, for additional procedure you're doing in the office. Now you can see the final result. So everybody has this patient. When the patient came to your office with the crown in her hands, on his hand, with the post. Look at the broken tooth. Look at the position of it. So now we have to remember it says below the gum level. What should we do? Do we have to do crown lancing procedure, or we have to do extrusion? So what's probably the best solution for this case? I have to keep in mind, if we want to save a tooth, or we're doing the procedure restorative, I have to keep in mind the rule is 2 plus 4 plus 2. 2 is occlusal reduction. 4 at the core length supposed to have, and 2 is ferrule effect. If we have those numbers, it doesn't matter what kind of restoration you have. It doesn't matter what kind of cement you're going to have. It's going to hold because you have mechanical retention. Of course, it depends also that's what the angle of interproximal walls you have. But that's rule we have to keep in mind. It's when we prep the teeth. So in this particular case, we have to place the implant on number 8, and we decided to have extrusion done. You can see I placed the post. I found the ferrule effect. We see the margin, the free gingival margin on number 8 is a little bit higher than number 9. And we know if we do the extraction, the margin will go up and it will not look great and cosmetically. So we decided to bring the margins with the bone, the gum and the bone, down. So when we extract, even with the resorption, we can get the same level, clinical level of 89. You can see the clinical, the root is very short. There is no way we can do the crown lancing procedure in this patient. You can see 1 week using Invisalign, but also the patient has the occlusal problem we call CCP. It's constricted chewing pattern. What it means, when the jaw wants to move forward, but the teeth in the way. So the circle of motion is right, but the teeth in the way. So we had to put regular braces all over the teeth to make sure we correct the bite and remove the source of the problem. And look at the final position after the braces were done. You can see the level of the bone and the gum are more down. So there is a rule. What we do with extrusion, if you want to move the teeth only but no bone, what you have to do is to, when you reach the level of the tooth structure and the bone is still going down, take a scalpel, go inside the sulcus and cut all the fibers, all the connective tissue 360 degrees. Then you're going to stop moving the bone towards the tooth structure. If you want to keep moving the bone with the soft tissue, you have to stabilize the tooth for 4 or 5 months until the bone and the soft tissue develop around this tooth structure. So once again, it's if you want to just to move the tooth without the bone, just cut these fibers 360 degrees so the bone will not follow the tooth structure. Let's keep in mind that if we do opposite procedure, if we're going to do intrusion, what we do in that case? Now people say that if we do the intrusion, the tooth will disappear around the gums. Usually it's not, because the bone will remodel in biological width. It's going to be keep the same. Just keep it in mind. So look at this picture. If we're doing this extrusion, you can have a bracket in your office. Okay, you can borrow from a local orthodontist. Just put the brackets on the height how much you want to extrude the tooth. You can see it from here. And then, as I told you before, it's if you want to just the tooth without a bone, just cut the tissue all around it, just the fibers. Okay, and you'll be alright. Keep it for 4 or 5 months until the tooth stabilizes in the socket. and then do restorative. Don't rush with the restorative, because sometimes, and most of the time, you will see the difference because the bone and the soft tissue didn't mature yet, didn't stabilize in the position where it's supposed to be, and your levels of the restoration is going to be different. There's another way that's to deal with the black triangles. You can see the Coys and other doctors been using fillers to fill the papilla. And what they do, they've been using 23 gauge needle and inject 3 mils below the papilla heights. Okay, what we usually do, look at this case. There's black triangles. The patient doesn't want to do any kind of procedures, and we're trying to fill those gaps. Those fillers will help you if you have like a millimeter distance to fill. But sometimes 1 millimeter will make a big difference for the patient. So what done is, in order to get most of the better clinical result of this patient, what I usually do, I go numb the patient, go with the scaler, and try to separate the papilla from underneath the bone. So the papilla will be free from the bone. Then calculate 3 millimeters below and inject the filler. So when I inject, I want to make sure that the tissue blanch and there's extra of material will start slipping through the sulcus. So I do the same from the lingual side. Then patient come back in 3 weeks, then reject again. And as you can see, the final result. Usually it lasts in the patient's mouth up to a year and a half, because this is not a movable tissue. You have to also keep in mind is make sure it's not movable tissue. Then you have better result. Biological weights and implants. There's a lot of discussion about it. And once again, remember, 4 millimeters in the proximal, the position of the bone, implant, I'm sorry, from the restorative margin, it has to be 3-4 millimeters. There's a study been done by Denis Tarnov, Mari Salama, David Garber in 2003. That biological width on the implant usually locates more subcrestally, the difference from natural tooth, which is more supracrestally. Because when we place the implant below the margin of the bone, and there's a connection between abutment and the implant, and usually biological widths start developing below the connection between abutment and the implant itself. And that's why you're going to see that therefore interdental tissue lacks the crestal support that exists between an implant and a tooth or 2 adjacent teeth. It means this because subcrestally. But look at over here, look at this diagram. You see that the biological width starts supracrestally on the tooth and subcrestally on the implant. But once again, if the implant and the tooth close to each other, less than 2 millimeters, or 2 millimeters or 1.5, the papilla will be held by position of the bone, remember it's on adjacent tooth, that's what's going to hold it. Even the position of the bone or the biological width is a little bit less here. So average papilla between those two implants, because again the position of the implant below the crest of the bone is 3.5, and papilla is going to be less in height compared to adjacent teeth. The horizontal component and biological weights consider 1.4. The only time probably you're going to get almost the same height if it's going to be one piece implant. So there's another study was done by Daniel Butler and Robert Shank. So they've been using to see biological weights between different implants system. Okay, 1 or 2 piece titanium implants. So where the biological weights? As I mentioned before, the one-piece implant is going to be more advantageous compared to two pieces implant because the biological weight is a little bit higher. You get more papilla out of it. So let's look at this case. This patient presents with a occlusal problem, but we're going to look at the only surgical and how the tissue is going to react. Of course, I'm going to deal this patient a little bit differently, but let me show you what happened. Those two central incisors are hopeless and has to be extracted. But I want you to see the position of those central incisors. You know, from the risk factors, if the teeth are more palatally located, it's better for the thickness of the facial bone. But look at the position again, number 8 to number 7. You have close number 9 to number 10. Remember again, the position, how it's going to react, the bone's going to react. So look at the facial bone. So the facial bone, you know that's most of the time it's very thin, and we're expecting recession, resorption. So the cone beam is going to give us a clue how much bone thickness do we have and how we're going to predict the case in the future. Look at the different tooths. Look at again the position of the infection. So look at again the proximally how thick number 8, how thin it's number 9. Look at again. That's why when I do the extraction, I try not to put my elevator in the proximally to kill in the proximal bone. I usually use from the palatal. We got primary closure. And remember how the bone resorbs, and we had the black triangle on this tooth. You can see that looking at the anatomy of the bone, we can predict the position of it. How it's going to affect our clinical result. Look at this case. Number 7 has to be extracted due to fracture. Look at the position of the bone and the gum. If we do just look clinically, looks perfectly, we can do immediate implant. But look at the X-ray. You see how bone is very thin. There is no 2 millimeters difference, 1.5 millimeter difference. Even though by doing the extraction, we're going to lose the bone. Then also, if we're doing the extrusion, because of the width of the root, even if we do the extrusion, we pull a tooth out, by resorption, we're still going to lose it. Look at over here. Placing the implant, and look how much recession we developed. That's why the immediate case will be dangerous. So I usually bone graft first, and then I place the implant. So let's summarize all the risk factors. You can see the flat scalp, okay, the more coronal position of the gum, okay, so less risk to have immediate implant placement. You can see more triangular shape, thin scalp or high scalp. That's going to give us high risk. Also thick biotype or thin biotype. Okay, so all these risk factors you have to keep in mind before making a clinical decision. Let's look at the last case. Look at the position of the gum. External resorption. Tooth has to be extracted. We put a bone graft. It healed in 3 months. And you can see how much soft tissue and bone tissue were lost. So remember the position of the facial was great. Why? Because again, the line angle to line angle of the bone was holding it. I place the implant, place more bone graft to regain what we lost, get a primary closure, placing the implant. Now we have to do soft tissue augmentation from the palate, temporary crown, and you can see that's a mock-up of the procedure. So thank you very much for listening. If you have any questions, please send me your email or put on discussion board. My email markgregorydds@yahoo.com. Thank you.